The Conversations on Health Equity Online video series is produced by the Health Policy Research Consortium, funded by the National Institute of Minority Health and Health Disparities. Located in Greenbelt, Maryland, under the leadership of our principal investigator, Kwesi Nfume, HPRC conducts policy research on issues related to health inequities throughout the country with a focus on the Mid-Atlantic region. HPRC uses a transdisciplinary research approach to close the gap between policy and science by assessing how current and proposed policies affect various populations. Major research efforts underway include the Health Policy Literacy Study, the Policy Portal, various research papers focusing on behavioral and social sciences, and a cardiovascular disease study focusing on disadvantage in the food, built, and social environment. For more information, visit our website or our social media channels.
Hello, I'm John Sankofa. Welcome to Conversations on Health Equity, an HPRC public policy series that takes a closer look at the challenge of health disparities in the Mid-Atlantic region and throughout the United States. Many groups, including African Americans, Hispanics, and low-income communities, face serious health inequities. For example, African American babies are twice as likely to die before reaching their first birthday compared to white infants. Recently, Dr. Perez Stable, the director of the National Institute on Minority Health and Health Disparities, NIMHD, said social justice must play a lead role in tackling health inequities. Today, we're delighted to have as our guest a person who essentially wrote the book on the subject. His name is Dr. Richard Hofrichter. He is the editor of Health Equity and Social Justice, a public health reader. Dr. Hofrichter is also the director of the Health Equity Program at the National Association of County and City Health Officials, better known as NACCHO. Dr. Hofrichter, thank you for joining us.
You're welcome.
It's a pleasure to have you. I want to begin in 1983. That must be a memorable year for you. I believe that's the year you earned your doctorate degree in politics. And I'm trying to understand what brought you from a doctorate degree in politics to becoming a public health strategist.
I guess I started, 1983, I was actually 38 years old at that point, and had been working quite a number of years in Washington for nonprofit organizations, the first of which was the Legal Services Program, providing social science research to the poverty attorneys for their legal cases. But in growing up, I was, as a boy watching daily the civil rights movement happen in front of me on television in terms of people being beaten and so forth. And the kinds of struggles that happened later on during the 60s, in my late teens and early 20s, there were a lot of protests that, I was a part of. And by the time I got to Washington, I was pretty much primed in terms of my interests. Over the years, I became somewhat more dissatisfied with conventional programs, to deal with these phenomena, and thought we need something more, a broader kind of social change. And so that really got me started into trying to, wherever I was, being someone who had a social justice perspective on all kinds of issues, because the inequities in the society are essentially everywhere in the society, wherever you are. You don't have to be in some power place like on Capitol Hill. Wherever you work, you're going to find these same phenomena. So by the time I got to the organization that I worked for, the National Association of County and City Health Officials, I was ready to jump in on whatever those issues were.
So it sounds like there's an internal compass that brought you toward social justice and health,
right,
that landed you where you are today.
Yes.
That's where I want to pick up. NACCHO, the National Association of County and City Health Officials. You run the Health Equity Program there. Can you first give us a sense of who is NACCHO? I don't know if folks are very familiar with NACCHO, the organization.
They are what we call the voice of local public health. They represent the almost 2,800 local health departments in the United States. Many of them are small, they're medium-sized, there's large ones, and they provide them with the necessary services, opportunities for interacting with each other, and basically trying to offer health departments in the country what they need to do their jobs effectively.
And one of the important programs in NACCHO, of course, is the Health Equity Program, and you run that program. Talk a little bit about that. When did that program begin, and what is its overarching objectives, and what is it trying to achieve?
The program has been in existence since the year 2000, and its major goal from the beginning has been to build the capacity of these local health departments to act more directly on the root causes of inequity in the distribution of illness, disease, and death. And over the years, we were able to obtain various grants from foundations and some other sources to build that program. In the year 2000, we received funds from the W.K. Kellogg Foundation that enabled us to put on a teleconference, a national teleconference, entitled Race, Class, and Health, that was seen by 475 of our local health departments. And that was the beginning of realizing that we had a constituency which nobody would have recognized before that. And that gave us some imprimatur to continue this work.
It seems to me what's really unique about the health equity program at NACCHO is that it doesn't focus on healthcare per se. It seems to be focusing on the root causes. And I want to talk a lot more about that. There's a lot of discussion about what causes health inequality between groups.
Right.
Is it differences in health behavior? Is it differences in access to health care? And we often hear the term social determinants of health, which we think has something to do with education and housing and income, which in itself is related to opportunity. If you could talk about the root causes and how that relates to these social determinants of health, help us understand that more.
Okay. The root causes are actually major injustices, social injustices in the society that have to do with structural racism, class oppression, and gender inequity. And there are many other kinds of injustices, but these are core to the society. They affect the entire society. And they are not so much related to social determinants of health as social determinants of health inequity, or the political determinations, as Nancy Krieger says, of health inequity. And that changes essentially the way we strategize and think about this. The social determinants of health are real, and you can make a list of them: housing, education, employment, transportation. But that's just a listing, and those are really literally things. Housing is a thing. What is making the housing unacceptable, unaffordable? What is causing some groups to have access to transportation and others not? There's a thread that runs through all of those social determinants, and they have to do with imbalances in political power. And it's basically that there are organized networks in the country that may not be visible on a daily basis. When you look out the window, you don't see them, but there are decisions being made, patterns of decisions that are affecting entire groups of people. There's a legacy of injustices that goes back a long way, but some describe it as a slow form of violence because it's not an immediate thing like a police shooting, but it's an aftermath in many cases. We can talk about this in a minute about when we talk about racism, but essentially people are experiencing negative conditions in which they live and stresses in their life that take a long time to manifest as disease. And that's why you don't see this on the front page of newspapers every day. But nonetheless, they are having things visited upon them by various institutions and patterns of decisions by those institutions that happen over and over again, so that you can't simply solve this problem through program and service. You can treat the consequences, ameliorate, and people in public health must do that every day. But you're not going to ever get at the inequity unless you do something else.
Now, I want to pause there for a moment because that's a fundamentally different way of thinking about health and populations. We often think that there's a need for more services, there's a need for more programs. But what you're saying is that's not necessarily what will close the gap. That's not what will end health inequities. It sounds like there's something far more structural that needs to be addressed. Now, a moment ago, you mentioned racism. And help us think about racism as a social determinant of health. How does racism affect human health? In what way does it create patterns of health inequity across populations? Help us think about that.
Okay. Well, racism, first of all, it's not a factor. You can't list that. It's an injustice. And once you think of it that way, you begin to think differently about what to do about it. It's something that's based upon a long legacy of social exclusion, marginalization, powerlessness, domination. You can just go on with this list of various kinds of oppression that have affected populations over hundreds of years, and leading to these differences in the distribution of disease and illness. And so you can provide those necessary services, but you're not going to get at what the racism itself is doing to people, the inequality that it creates, and the difficulties in living a flourishing existence. Let me give you an example or two. There was a study done a long time ago on a military base in California where the African American women had significantly lower birth weight in their babies. On that base, everything was the same. You had the same clothing, the same barracks, the same food, and I can go on and on with all of the material conditions were the same. So what was different? The stresses of racism. And this was documented a number of times in other places. Similarly, you can look at West Harlem in New York City for many years had the highest level of asthma, I believe, on the East Coast. And how does that happen? I mean, you can give everybody an inhaler, you can put a clinic on every corner, but they continue to have these high levels of asthma. Well, it turns out that in the borough of Manhattan, they had 75% of the city's polluting sites, wastewater treatment plant, bus depots, landfills, I mean, a whole range of pollution. And you're not going to necessarily see the decision processes that made that. The decision processes by banks, by real estate developers, by the Chamber of Commerce, by members of the city council that located that level of toxicity in that neighborhood.
So it sounds to me then like policy can make a difference, at least in the case of Harlem, where if there are certain neighborhoods where there are more bus depots sending off more pollution into local neighborhoods, there must be policies that could in some way regulate that. In the other scenario, you mentioned the military base where black women were having higher rates of low birth weight, which is a risk factor for infant mortality, and racism being a factor in there. I'm not clear what might be the policy intervention for that.
Well, that is part of the problem, is that there isn't necessarily a policy piece per se. It isn't as if somebody forgot to do something. In the case of West Harlem, yes, again, as I say, you can have all sorts of treatment plans, but to stop it, you have to do something about the decision-making. You have to democratize decision-making so that the communities are not surprised one day to wake up and find these things in their neighborhood. And that's part of the problem. You have, again, organized networks of power making decisions without input from the communities who will lose out. Communities who will be dispossessed when a developer comes in and says they're going to take out a neighborhood to build condominiums. You know, where is the justice in that? Where is the decision process that involve these people who are going to be dispossessed, causing stress in and of itself in those communities? Public health has a responsibility to do something. It's not a simple answer, but they need to find themselves allies and make this public and understand that these kinds of land use decisions and other decisions like that can be dealt with, but not through some individual quick fix